Hey, this is Dr. Lenicky, and I am going to do a podcast here on parts of Chapter 15 and spinal pathologies. All right, the first we want to talk about is pathology of the intervertebral disc. So a herniation is where the disc material has gone beyond the normal limits of where the intervertebral disc should be. And there are three types of herniations. One is a protrusion. So this is where the herniation has displaced, but the disc material remains within the disc. An extrusion is another type of disc herniation where the disc material moves beyond the posterior longitudinal ligament or beyond the intervertebral disc space. And then sequestration is when the disc material has moved away from the disc. So this picture is showing different varying amounts of disc breakdown. So the first one is a breakdown of the fibrous layers, and the annulus has some displacement, but it's still within the disc material. In picture B, there are some fissures that you may see that are starting to break, and the material is bulging out against the outer area of the annulus. So this would be considered a disc protrusion. Where in C there is disc material that is starting to move through the disc, but it still is in contact with the disc. So this is a extrusion. Where in D there's sequestration. So the nuclear material has moved beyond the annulus, and it is actually a separate piece of material. All right, so there can be breakdown of the disc, and that's usually what's happening. This occurs with a lot of axial overload or a lot of pressure through the spine. You'll see this with around here a lot with those who have been on airborne status and had a lot of airborne operations where they've had repeated falls or repeated jump landings. Your discs also break down with age. There can be degenerative changes, especially with repeated forward movements, and these forward movements are what causes the disc to move posteriorly. So if we go back to the previous slide, you see that the typical disc here is moving posteriorly, and sometimes posterior laterally, because that is a weaker area of the disc. Also, with disc breakdown, and as the disc loses height, you're going to have an increased mobility in that segment. So the disc is not taking as much space, and you may have more movement within the vertebral column. This movement, though, isn't necessarily good. You will have greater shear forces, more forward and backward translation, and that leads to segmental instability. All right, so we're going to talk about tissue fluid stasis. So during repeated flexion movements or even sustained flexion movements, there's compression on the anterior aspect of that vertebral disc. Over time, creep occurs where the fluid moves towards the posterior aspect of the disc, and ligamentous stretch may occur. This creates a disc that is no longer completely flat. It's almost in a wedge or a triangular position. And that's why when many people have sustained flexion movements, they go to stand up, it's more difficult because that disc is now thicker in the back and thinner in the front. And it is a factor of creep. It can return, and this is one of the main reasons why repeated extension can benefit patients even when they don't have a true disc bulge. Many people don't understand the difference, and so they think as soon as they're doing repeated extension exercises, they're automatically treating a disc bulge. It may just be that they're treating a disc that has had a lot of creep and has changed its shape. Right, when it comes to signs and symptoms of either disc lesions or this fluid stasis movement, the typical symptom you're going to see initially is pain. But you need to be careful. Only about one-third, the outer one-third of the annulus is innervated. So until the problem is significant, they may not have pain. Other signs are neurological signs. These neurological signs can be true nerve or spinal cord pressure if the disc bulge is that significant, but it can also be referred pain. So referred pain can occur from stimuli of the spinal muscles, the interspinous ligaments, the disc, the facet joints. So there may not be true nerve root pressure, but there is going to be referred pain. So symptoms of a disc lesion can be varied, and mainly because the disc can protrude in many different directions. Posterior and posterior lateral are definitely the most common. When you get a posterior lateral bulge, it may cause some spinal cord symptoms, but typically a posterior lateral is going to hit more on those nerve roots, where a direct posterior may cause more spinal cord issues. Some of the spinal cord issues you need to be concerned about is loss of bladder control or anesthesia in the saddle area. If that is the case and patients are having bladder control problems or saddle anesthesia, that's an emergent referral. So you often send them to the emergency room with signs of a cauda equina syndrome. If there is an anterior bulge, it's pushing only on the anterior longitudinal ligament. That can result in back pain, but there's no neurological areas. So the spinal cord is not there, the nerve roots are not there, so there's not going to create the neurological signs. And often with disc lesions or those who have fluid stasis changes, their symptoms may shift. So at one point, if they have increased the fluid shift or increased the pressure anteriorly so that the shift moves more posteriorly, their symptoms are going to be greater. To where if they get postures that are either putting an even amount of pressure on the disc or even extending the spine, that can shift the fluid anteriorly and lessen the symptoms. And if the contents of the disc material are extruded and sequestered into the dural sac or to anywhere within the neural canal, they can irritate the dural sac, the nerve roots, and the nerve root sleeves. This can cause not necessarily pressure that's mechanical related, meaning that movement, inflection, or extension will change the pain. They need to be treated with anti-inflammatories, and medical intervention may be needed if this sequestration is causing symptoms. So in other words, if disc material is into that neural canal, surgery may need to occur so that they can go in and remove this material. Alright, individuals who have intervertebral disc or the fluid stasis issues with a disc typically have an onset of pain that refers down either the arm for the cervical spine, sometimes the scapula for the cervical spine, or down the leg. This phenomenon, we're going to talk about this more later, is peripheralization. So when the pain moves from a central position to a peripheral position, so in other words, if they have pain in their butt and then it goes to their foot, that's called peripheralization. And as the pain is able to move back closer to the back, that's centralization. A problem that goes to the distal extremity, so here on the fifth picture on the leg, or on the sixth picture of the arm where the pain goes all the way to the hand, that's a bigger problem than someone who just has some low back pain or pain into the buttock and thigh, or here pain into the upper trap area, or upper trap and scapula. Typical people who have disc problems are usually between the ages of 20 and 55, with most people being in their 30s and 40s. Unless it's a trauma, typically it doesn't occur outside of those age ranges. For both the cervical and the lumbar spine, prolonged flexion will exacerbate the symptoms of a disc bulge. So the typical patient that comes in with a disc problem, they're usually they're not going to be comfortable sitting. They prefer to stand and walk. These are the patients that if you ask them, what are you doing when the pain comes on? They'll say, I wasn't doing anything. And if you dig further, you'll find they were sitting on the couch or sitting at work. usually in a seated position where they have that increase in lumbar or decrease in lumbar lordosis, so sometimes even moving into a kyphotic posture that's putting pressure on the anterior part of that disc and pushing it backwards. Initially, backward bending may be limited because remember that fluid stasis has changed where the fluid is now moved. There's more in the posterior aspect and the disc is wedged. Once they're up, if you can return the creep back to a normal position, they enjoy being in an extended position. If you're assessing these individuals and you have them do trunk flexion, either in a standing position or in a supine position, such as double kneaded chest, that tends to peripheralize their symptoms. Okay, so what's the relationship between this disc and the wear and tear in the disc and the facet joints? So initially with disc degeneration, there's an increased slack and an increase of mobility and translation of the spinal segment. So this causes the facet joints to have more strain on them. They may be irritated or swollen. And as we know, in irritated, painful, swollen joints, muscle control decreases. So that the muscles that will help to stabilize the spine are not going to be working as well because they're painful. So with repeated irritation, with repeated problems to the lumbar spine, you will get bony changes. This can be called spondylosis in some patients, osteoarthritis, or degenerative joint disease. It's all related. You may see osteophyte formation or bone spur formation along the facets. You may get some bony formation where the disc and the vertebrae meet. And some of these discs may narrow the foramen where the nerves pass, or even the foramen where the spinal cord is. And as we've mentioned somewhat before, the related things that can occur with intervertebral disc and facet joint pathology is you will get some segmental or clinical instability. You also get stenosis, which is narrowing of those canals. You may have neurological symptoms, which is a radiculopathy down the leg. And you will also have some dysfunctions such as muscle splinting, pain. This may further restrict the movement. Okay, now we're going to talk about the facet joints, or the zygapophyseal joints. Facet is easier to say, so we're going to stick with facet joint. So some common pathologies that you may see with facet joints. One is a facet joint sprain or a joint capsule injury. This is much more common if there's a trauma, a fall, or a motor vehicle accident. You can see the osteoarthritis, spondylosis, and degenerative joint disease. This is when you're getting bone spurs, wear and tear of those joints. Also, there is a relationship between facet joint problems and rheumatoid arthritis. In individuals who have rheumatoid arthritis, they're more likely to get some degeneration throughout the, especially the cervical spine. It's very common to see atlantoaxial subluxation, so be very careful. You would not do spinal mobilizations or manipulations to individuals who have rheumatoid arthritis. They also tend to get C4-5 and C5-6 dislocations from the wear and tear. Individuals who have a disease called ankylosing spondylitis have chronic inflammation of the ligaments around the lumbar spine. In about 20% of individuals with ankylosing spondylitis, they have fusion in many of their bones, especially at the spine. It's relatively common, so between 1 and 3 people per 1,000 get it, and you're usually diagnosed relatively early in your mid-20s. So if you have a 60-year-old coming in who's never had this diagnosis, this is not the first thing you should be thinking of. In the case of, if they have hypomobility, their hypomobility is probably not from ankylosing spondylitis. But if you get someone in their 20s and they have significant loss of motion, you need to consider this. If you are seeing a patient and you suspect ankylosing spondylitis, some of the symptoms that have been indicative of diagnosis is that they have stiffness for greater than 30 minutes in their back. Their pain is improved with movement such as exercise, but their pain is worse with rest. Also, they will have pain that wakes them up in the second half of the night, and they may have buttock pain that alternates from one side to the other. And the last facet joint pathology we're going to discuss is facet joint impingement. So you can get tiny parts of the facet joint capsule entrapped or impinged. And usually this occurs when you're doing a forward flexed and rotated movement. So you've fully opened up that facet joint, and upon returning you get an entrapment of the joint capsule. Symptoms of this include loss of specific movement. So in other words, if the right side, and let's say in the cervical spine, if the right facet joint gets impinged when it is open, you're going to have difficulty extending the neck, side bending the neck to the right, and rotating the neck to the right, which are all activities that close down that facet joint. But there's something impinged in there and it's not wanting to close. Right, now we're going to talk about pathologies of that vertebrae. So one is a compression fracture, and usually this occurs secondary to osteoporosis. We've talked about osteoporosis several times, but these usually occur in the 6th or 7th decade. The pain will be referred to the low back. It may even refer into the abdominal region. There may or may not be any lower extremity radiculopathy. These patients usually present with an increase in kyphosis. There's a thing called a dowager's hump, which is that anterior kyphotic posture that many individuals with prolonged poor posture tend to develop. Cervical interventions such as something called a vertebroplasty may be indicated in severe cases. So they now do surgeries where they stick a needle in and fill up the vertebrae with a substance to create a height in that disc and to make it more stable. And some of the risk factors for a spinal fracture include being over 50, being female, having a major trauma, so being in a car wreck, falling from a higher level, having pain and tenderness, and a painful injury. If you have more than 3 of the following, you have a pretty high rate. You have at least about a 50% probability of having a compression fracture. And the final vertebral pathology we're going to talk about is Scheuermann's disease. This is a disease that usually occurs in younger individuals, so around the teens. It is a congenital and degenerative weakening of the vertebral end plates, and it usually causes an increase in thoracic kyphosis. So the normal curve is here. Somebody with Scheuermann's, they have a significant curve. There's been no pathology, so many physicians will diagnose it as growing pains, especially until they start to see changes. So anytime you're treating a younger individual who's starting to have back pain for unknown etiology or unknown reasons, at least consider Scheuermann's disease. And now to talk about different pathologies related to muscle and soft tissue. So just like every other muscle, you can strain it. You can get wear and tear and overuse. Think of all the times you've strained a muscle trying to do a new activity. So the symptoms of a trauma from a strain or tear is pain. You may get localized swelling. You'll have tenderness over the muscle that's painful. You may also get protective muscle guarding. This, is your body's reaction to any kind of stress. If it's a ligamentous pain, you'll have an increase in pain if that ligament is stressed. Right, common sites of lumbar strain, usually along the iliac crest. So think of muscles such as the thoracolumbar fascia, the quadratus lumborum, your erector spinae, your iliolumbar ligaments. And so all of these go along that lumbar spine. Injury can occur with falls or with repeated loading, so too heavy of a lift. In the cervical spine, you can get flexion or extension injuries. with extension injuries, you will have an increase in cervical extension. And this can stretch the anterior structures such as the longus colli, the suprahyoid, the infrahyoid, but it also can put stress on those posterior structures as the facet joints start to close. With flexion injuries, it's a rapid acceleration into flexion, and usually the only thing, you have enough mobility that your chin hitting your sternum may be the only thing that stops it. And so this, you will get the posterior cervical muscles, ligaments, and fascia stretched, and you may get pain from that. All right, that's all for this podcast. I may either podcast more or lecture more on this chapter. See you soon.